So I'd like to introduce Dr. Carol Swallow. And Dr. Carol Swallow, she's a surgical oncologist specializing in gastrointestinal cancer. She's the division head of general surgery here at Mount Sinai Hospital. She's the Bernard and Raina Langer Chair for the Division of General Surgery and the professor at University of Toronto. So please, Dr. Swallow.
Thank you very, very much, Katie. It's a pleasure and a thrill to see you again, as always. And I want to thank both you and Teresa for the very kind invitation to be here today. I'll also just say that I think that's a very tough question that you asked, and I'm not going to address it specifically in my talk, but we can certainly come back to it later, because I think it's quite relevant. But what I thought I would focus on is some myths that patients tend to have fixed in their minds when they come in to see a surgeon for the first time to discuss gastric cancer surgery. I'm not going to really debunk these myths totally because, like all myths, they have a core of truth, some kind of kernel of something that is real at the heart of them. And so what I'm hoping to do is just give you some core principles about each one and then show you some of the evidence as we go along. So I'll start off with number one, which probably all of the surgeons here have heard. How can I live without my stomach? I mean, what are you talking about? How can there be any life without a stomach? And that is illustrated very cleverly, I think, in this little drawing by Eleanor Davis of what people imagine when they hear they're going to have a gastrectomy. And of course, all of you who've had a gastrectomy know that that's not what we do. Just to put us all on the same page, I'm showing the two most common types of gastrectomy. This is a subtotal gastrectomy that is done for a cancer that is in the distal stomach, and most typically would be reconstructed with what we call a Billroth 2 reconstruction. That's a gastrojejnostomy, so where the stomach and the small bowel are joined together a little further down the way. And then the other type is a total gastrectomy. You've heard that talked about as a TG. And that's where we take out the entire stomach from the esophagus to the duodenum, and then we do this Roux-en-Y reconstruction with the jejunum brought up to the distal esophagus, and another anastomosis further down to prevent bile reflux. At least that's the intention. A lot of people will ask, why can't you just take that little piece out, as Dr. Tashima alluded to? What's with this huge piece of stomach that needs to be removed? And of course, that goes back to having to take out the lymph nodes. You see those illustrated here in yellow, the ones that are just around the stomach, and then the higher echelon lymph nodes here that are more around the aorta, the celiac artery, and the left hepatic artery origin. The D1 dissection, which many of you have heard about, is a type of lymph node dissection that removes the entire omentum. That's what you see here. And the lymph nodes around the stomach. This is this lower part of the stomach right here, and these lymph nodes are removed. A D2 dissection removes all of that, plus more lymph nodes in that higher echelon, and the splenic artery origin, the hepatic artery origin, and the celiac in this area. And you can imagine that's a fairly delicate little area. There's been a lot of controversy in the surgical literature about whether a D2 dissection is better than a D1 dissection. I'm sure many of you are familiar with this argument. I think it may be of more interest to surgeons than patients, but some of you will have read all of this. There is some long-term evidence from a Dutch randomized control trial in very long-term follow-up that people who have had a D2 dissection have less death due to cancer in the very long term. However, this question is still really unresolved. A recent Italian randomized control trial of these two techniques looking at long-term survival, found no difference in overall survival at 5 years between the two techniques. So I would say the jury is still out, but that most people, most surgeons who specialize in gastric cancer do a D2 dissection. One thing we do know is that it's equivalent for a distal gastric cancer, one in the antrum, whether you do a subtotal or a total gastrectomy. So the 5-year survival is the same whether you take out the whole stomach or part of the stomach. So obviously we want to do part of the stomach if possible for cancer reasons. Myth number 2, I will never enjoy eating with friends and family again. And I'm sure this rings very true for many of you. And I think, as I said, there's a core of truth about this, especially during the early days, months, and maybe years after your gastrectomy, before you sort of figure out what works for you. The post-gastrectomy syndrome or syndromes, these are very real complications and can plague your life for some time. We also know that those symptoms are worse in patients who've had a total gastrectomy than a distal gastrectomy. And here you see a way of representing how severe symptoms are. And the total gastrectomy is outside of the distal gastrectomy for all of these different types of symptoms. There has been a recent randomized trial trying to minimize the weight loss after total gastrectomy for gastric cancer. This is actually in early gastric cancer patients, using an immunonutrition supplement, and this is eicosapentaenoic acid supplementation, which was associated with about 600 kilocalories a day as well. But as you can see, to the disappointment of the investigators, the weight loss was no different with this supplementation compared to a standard diet. So people are still working on this, and you can get lots of advice from friends, which I guess we're all friends here, from some online sources, from dietitians, but I completely agree with those of you who've said this is one of the biggest challenges that you face. I think one of the things that's important in facing the challenge is your social supports, how you view healthy eating, and whether your social supports encourage you enough to eat healthily, and also underlying depression. And that's what was found in this Japanese study, that people who have depression and social isolation are much more likely to have difficulty with post-gastrectomy syndrome symptoms. Myth number 3, my quality of life is going to suck. And I think someone this morning did use the word suck. Having a gastrectomy, not being able to eat normally impacts on all of these factors, and they all in turn impact on the way you eat, and that changes your quality of life. So it requires a lot of attention to mitigate these factors. It takes a lot of energy and activity and support. So we can see here in terms of quality of life measures that quality of life is worse in patients who have stage 3 cancer after gastrectomy compared to stage 2 or 1. Also, patients who've had a total gastrectomy, their quality of life scores are worse than patients who've had a distal gastrectomy. So coming back to the point that a subtotal gastrectomy is preferred if it's appropriate for cancer reasons. However, having said all that, in a population of patients who really didn't have any gross disease, this is the CDH1 mutation patients, and many of you are here today who contributed to this data set. We here found that although weight loss is inevitable, it does eventually plateau, and quality of life goes down at the beginning, but then recovers and comes back up to a steady state. So I think that there is hope, and that with conscious attention and support, these symptoms and the quality of life impact can be mitigated. Myth number 4. It would be better if they just cut it out. So, of course, the surgeons in the audience will know that we hear this very frequently. But I want to just caution you, there are a few things that need to be done before you jump into surgery. One is staging. It's very important to know what stage your cancer is at before we make a management plan. So this illustrates the inside, as Chris just showed you. Here's the cancer, here's the pathologist's view of it down a microscope. But we need to know how far does this cancer invade through the gastric wall, and endoscopic ultrasound is a very good way of assessing that. And we need to look through, can I go back? A lot. Okay. Previous. Okay. I'm just going to sort of go hands-free here because it's very sensitive. We need to also look for distant metastases. We do that with a CT scan typically, and you can see here liver is shown nicely. This is the primary gastric cancer here in the antrum. Here's metastases in the omentum, so that's peritoneal type of metastases. And here's a metastasis in a lymph node in the neck. So staging also includes, for most patients, performing a staging laparoscopy. And you can see various levels of involvement of the peritoneal lining here at laparoscopy. Some a little bit more dense and thick deposits of tumor than others. Staging laparoscopy is very accurate and can also help us to assess resectability. And the treatment plan actually changes in 20 to 30% of patients who have a normal-looking CT scan with no metastases. It's also a chance for us to perform a peritoneal lavage and do cytology, and I'll come back to that later. The other reason we want to get a bit more information before we leap into surgery is because we know there's a percentage of patients who benefit from adjuvant therapy. And you heard about this earlier from Stephanie. This was the landmark trial of postoperative adjuvant chemoradiation using the McDonald regimen, which first established that there was something that you could do besides surgery that helped save lives of gastric cancer patients. And that was published in the New England Journal in 2001. Note, though, that only 10% of the patients in that trial had what we would consider standard lymphadenectomy. So most of the patients had what we would consider inadequate surgery before they had their postoperative treatment. So there's always been a question of whether with adequate surgery, would there have been any benefit? The MAGIC trial comes somewhat further in addressing that question, and this was the MRC UK-based trial that compared preoperative chemo, surgery, and postoperative chemo to surgery alone. And here you can see a remarkable almost 15% absolute difference in overall survival at 5 years. Okay. Current adjuvant trials of interest. You saw this before in Stephanie's presentation, the CRITICS trial. And I want to just remind you about the Top Gear trial, which we are participating in here in Toronto. This compares patients who've had preoperative chemo and surgery to patients who've had pre-op chemo, radiation, and surgery. And it's a very ambitious trial. It's being run across 3 continents. And the Canadian Cancer Trials Group is very proud to participate in this at centers all across Canada. Basically, currently, the protocol is to randomize people with non-metastatic cancer of this stage to either FLOT with radiation or FLOT alone, surgery, and then FLOT afterwards. So we are actively recruiting patients to this trial. Myth number 5, surgery for gastric cancer is too risky, and you heard a little bit about this earlier in the day. And I can see why people might think so based on results such as this, which is from the Dutch randomized control trial that I mentioned earlier. And you can see here with D2 lymphadenectomy in this trial, as it was done at that time, the mortality postoperatively was 10%. So 1 out of 10 people died from the surgery. That's pretty high. Since then, the technique has been changed and improved, and the mortality rate using the same operative technique has got down to less than 5% in most centers in the West. So it's considered safe. And these are complications that we've seen here at Mount Sinai Hospital in D2 dissection with gastrectomy. Over this time interval, you can see the complication rates. So I would say it's reasonably safe at this time. Myth number 6, gastric cancer recurs in most people. And again, if you look at old literature, it does seem to be that way. This is the North American result. Even with stage 1 gastric cancer, only 50% of people were living to 5 years, compared to Japan, where almost 100% with that stage were living to 5 years. And then you can see with advancing stage in North America, the figures got even more grim. However, since that time in the 1990s and 1980s, things have really improved. And these are our results most recently here at our hospital with gastrectomy and D2 dissection. Here you can see stage 1, over 80%, 5-year survival. Stage 2, close to that, about 75%, 5-year. And it's at stage 3 that it drops down to around 30%. But that's a lot better than it used to be. And why is that? Well, I think you've heard a little bit about why that is with the presentations here today. We have better staging, better patient selection, better surgical technique, better perioperative care from anesthesia and nursing, and better adjuvant treatment. Myth number 7, once it has spread, there is nothing the surgeon can do. And, you know, again, there is some truth to this, certainly with some patients, and a lot depends on the details. You're looking at some liver metastases here on a CT scan, peritoneal metastases, a lung met, ovarian metastasis, lighting up on this PET scan. And it's quite true that if you look in laparoscopically and you see gross peritoneal disease, the prognosis of that patient is not very good. In this series from Memorial Sloan Kettering, the median survival was 10 months. And it's not just gross peritoneal disease that shortens survival, it's also cytology positive. So I talked about lavaging the peritoneal cavity and looking for cytology, that's isolated cells. And about 10% more on top of the 20% have gross disease, have cells in the peritoneal cavity. This is from MD Anderson Cancer Center. The prognosis of those patients with cytology positive gastric cancer when they're resected is notably better than those who have gross peritoneal disease. So you can see here it's 16 months median survival rather than 10. But should those patients actually have their primary cancer taken out? And this is one of the big questions that patients will ask. What are you saying to me? Because I had these few cells in my peritoneal cavity, I shouldn't have my stomach taken out? I guess you can't get me back to where I was, right? Is that right? I have to go back myself? Okay. Oh, you're going to see all my fantastic slides.
Just go this way. Oh, okay.
Okay, here. And full screen. So this group in Korea were very enthused about doing gastrectomy for patients with cytology positive disease. And their result was 21 months median survival with resection of the stomach in that setting. And that's what they're advocating for. But there is no randomized trial of that. Another thing you may have heard is the term conversion treatment, where someone who has cytology positive or minimal volume peritoneal cancer undergoes chemotherapy with a good response and then gets HIPEC, which we mentioned earlier. It's heated intraperitoneal chemotherapy in an attempt to convert them to cytology negative. And once they convert, then they're candidates for having a gastrectomy. And that is something that's being done under study principles at MD Anderson Cancer Center, recognizing that this group of patients may have a better prognosis than others. But I just want to remind you, in the one randomized trial that was run at multiple centers in Japan, where they compared chemotherapy alone to surgery plus chemotherapy for patients who had distant metastatic disease, there was no difference in the survival, so the surgery didn't seem to be of benefit. There's some other options, such as radiofrequency ablation for liver metastases, and there's also new kinds of radiation, such as SBRT, that can help with controlling liver metastases. As we look out on a landscape where patients with gastric cancer, as you heard earlier, are living through distant metastatic disease for a lot longer, and there is a lot more hope. I'm just going to point out that part of the FLOT trial series was to look at patients with limited volume metastatic disease, this is the B category here, who responded to IV chemotherapy and then had resection of their primary and of their metastases. And this is the survival curve in that patient group. And that's a lot better than we ever would have expected in the past. There's also some suggestion that you heard about MSI High and immunotherapy earlier. MSI High patients may actually do better with resection of their primary and their metastasis than microsatellite stable patients. So that's the Lynch syndrome group. Myth number 8, I should have my gallbladder removed at the time of my gastric cancer procedure. And I think it's Leanne who had problems with her gallbladder after the gastrectomy, which is quite interesting and sort of runs counter to my argument here. But it's been thought for a long time that because when we do the gastrectomy, we interrupt the vagus nerve, there would be improper nerve impulses going to the gallbladder. It wouldn't empty, it would develop stones at a high rate, and you'd need to have your gallbladder out later. And I think that's probably true for people who have an underlying predisposition to gallstones. But there is one randomized trial. They randomized people who were having a gastrectomy to gallbladder out or gallbladder stays in. And overall, there's no difference in the outcome with these patients in terms of complications. And they would have had to do 32 prophylactic cholecystectomies for one patient to get benefit. So, final myth, surgeons are only interested in the procedure, not the patient. And that is clearly untrue. I think that any of you who've had a relationship with a surgeon, which is all of you who've had gastrectomies, remember who that person was, and they probably remember who you were. It's a very special bond. And I think surgical oncologists and surgeons in general are paying a lot more attention to communication, content of communication, style of communication. This is from a recent article that talked about what do patients want to know, how can we learn to ask open-ended questions and be more honest, more open about discussing the pros and cons of different procedures and involving patients. So that we're engaging in a shared decision, such as your patient, Chris, who, she knew what the risks would be, what the possible outcomes would be, and she opted for a certain procedure. And I think we're all evolving towards doing that together rather than having the surgeon dictate what is going to happen. I hope that's true. And with that, I will finish. Thank you very much.
Can I ask a question which may not be yours, but does anybody know in Canada, what most gastric cancers are diagnosed, at what stage would they be?
So it's still, unfortunately, about half of people who have stage 4 disease at the time of diagnosis, which is distant metastases.
Yeah.
And we're still seeing mostly stage 2 and 3. and not so much early gastric cancer
Right.
in Canada, because as we talked about before, we don't do screening here.
What about in Japan? Would that be half as stage 4?
Stage 1.
Stage 1? Oh my goodness.
Yeah, it's completely different.
We're facing a prophylactic GT, and I'm just over here.
Okay, yes.
I was curious, the slide you had about quality of life, I couldn't read the bottom in terms of the average number of months. So what is the typical recovery time?
Yeah, that's a good question. So by 1 year, most people have come back close to their baseline. And then by 2 years, the majority of those continue at the same level. But we had 2 or 3 people who by 2 years, their quality of life had declined again. And my own personal theory is that by that point, people kind of expect that they'll be normal, and they have these persistent symptoms. And so that really is frustrating and depressing. And so that has an effect on quality of life. And I really would echo the sentiments expressed earlier about needing maintenance long-term. This isn't something that takes you 6 weeks to get over and you're back to work and everything's fine, the way it is for many other cancer operations these days. There are permanent effects that you have to learn how to live with and live better with very long-term. And things may change in your life that necessitate another intervention later on. So we're very interested in our group in what we can do to support patients going forward, not just in the first 2 years, but after that.
I think just to add more to that is if you surround I'm up here. If you surround yourself with a good family and support system, getting back to your regular quality of life it takes time, but it's really not that difficult with a good support system. And it seems that you have one over there.
Amen to that. Thank you very much.